Research on data-driven methods for mental health analysis has gained a lot of traction in the last decade, in part due to the rise of social media, which created an abundance of publicly available personal data. And perhaps surprisingly, people do discuss their personal health concerns online, including mental health issues. This created opportunities to develop methods to quantify mental health status on social media, both at the individual and population level. But before getting into the specifics of these methods, let's take a step back and look at the premise that underlines this line of work. What we say and how we say it, or what and how we write, provides clues to our mental health status. Research done in the 30s and 40s established that motivational, mental, and personality characteristics could be gleaned from these personal writings. This means that we can use text analytics and natural language processing tools to measure psychological constructs from these writings. This is actually similar to questionnaires that are routinely used by psychologists, such as the PHQ-9. These are designed by defining a construct of interest, say depression, and devising an instrument to measure this construct, a set of questions and a scale in this case. Similarly, we can identify words, groups of words or expressions that are indicative of these psychological constructs. Indeed, there has been a lot of work devoted to creating psychometrically validated dictionaries. These are sets of words annotated with their associated affective, emotional, and psychological aspects. Examples of such resources include the Linguistic Inquiry in Word Count, or LIWC, and the Effective Norms for English Words, or ANEW. So the idea is that we can take personal writings such as diaries and essays, but also text messages and social media postings, and use frequencies of these annotated words to quantify psychological constructs. Another question we should ask is, why would we want to use social media data to address the mental health crisis? And to answer this, let's look at this plot. The x-axis is a timeline. The red hashes show when a given person visited their therapist, and the blue hashes show when they posted something on social media. The point here is that there are these gaps in between visits. There are actually when the mental and behavioral health conditions manifest. This is what Glenn and colleagues call the clinical white space. And this is where computational methods that can passively monitor a person's mental health over time could be really powerful. For example, to prevent crisis by providing timely alerts to either the person or their doctor if their mental health declines and crosses some thresholds. Or to identify what conditions and behaviors affect a person's mental health. Or to assess the efficacy of interventions in real time. At a population level, we could use these methods to get more accurate estimates of prevalence that also account for underrepresented groups that are often excluded from the healthcare system. This, in turn, can inform the deployment of targeted public health interventions. In our work, we combine mental health classifiers with demographic inference models to understand how these conditions affect different groups. The plot shows the prevalence of depression on a cohort of 10,000 social media users, stratified by demographics. Crucially, social media-based surveillance can be cheaper, faster, and more responsive than traditional public health surveillance.